Thank you very much for the kind introduction. I'm honored to be invited to give this update guidelines of inguinal hernia repair and what's new. Okay, I have no conflict of interest. It all started with Hernia Search Group. Hernia Search Group is a group of experts from Europe, America, Asia, Australia, and around the world. And it's cooperated by the EHS, IEHS, APHS, and American Hernia Society, as well as Australasian and African and Middle East Hernia Society. I represent the APHS, one of the three APHS in this hernia search group, the original one. And we met in many countries, mainly in Europe, to develop this guideline since year 2013. It takes few years, and this was in Cologne and Milan. And finally, we get the guideline published in year 2018, International Guidelines for Groin Hernia Management. The key for this guideline is we use only the high-grade evidence for the guideline. So if there's not enough evidence, we just leave it out. Okay, and it was published. And we also have another consensus. I'm also in this group. We conduct the consensus from the guideline, and finally, they are all accepted and adopted by all society, including our APHS, Asia Pacific Hernia Society. And I myself, I have written and published the highlights at that time for easier, because the main guidelines, there were several hundreds of pages, difficult. So I highlighted, and it was published as well. And then come for the update, because after 5 years, we have new evidence, so it needed to be upgraded and updated. So the hernia search group, not the whole group, but some of the group with the newer experts were in this group. I'm not included in this group, and no Asian representative is in this group. It's dominated by mainly European Hernia Society and some in American Hernia Society. So it's majority European side, and also one Australian. So this is the newest one, the update, and it's published in BJS Open in year 2023, just a few months ago. It's also referenced the previous international guideline as well as the consensus that we published. The team that represent a different group on guideline come up with about 10 topics of updates, namely tissue repair, open peritoneal repair, laparoendoscopic repair, occult hernia, mesh, antibiotics, anesthesia, chronic pain, emergency hernia surgery, as well as a non-commercial mesh. What's the position on? I would not go into details. The details you can look up, but I will just highlight the point of updates. I just also want to show you that it have also gone through the consensus So finally, the third consensus, everybody agree with the statement and recommendation. The first one, preferred hernia. What is our position right now, mesh or non-mesh? The latest evidence shows that mesh and non-mesh are effective approach, and both have different benefits. But mesh-based reduce the risk of recurrence. This is the most important one, without increased risk of chronic pain. And selected group with primary unilateral show-dice technique have probably similar outcome comparable to Liechtenstein as well as the endoscopic. Even with this, the recommendation is mesh-based repair is recommended in majority of the patient. So this is a strong recommendation. And non-mesh repair can be suggested for selected patient. Okay, so standard right now is mesh-based. For non-mesh technique, which one is preferred? Tissue repair. Show-die have lower recurrence rate than suture repair. There's a new, the SADA technique, very popular right now, but there is not enough evidence. So recommendation is that if it's non-mesh or tissue repair, show-die is probably the best. For open preperitoneal mesh versus Liechtenstein, what is the new evidence? Currently, open preperitoneal technique can achieve comparable result like recurrence, but not enough to compare between different type of preperitoneal mesh. Okay, and preperitoneal mesh technique achieve favorable result in terms of operating time, chronic pain, return to work, but there is no evidence for the best technique to treat recurrence of the former preperitoneal repair. The problem is if we start open preperitoneal, we use all the space, anterior space, posterior space, so if there's recurrence, it's more difficult to have the repair of the recurrence. So the recommendation is in open surgery, a peritoneal flat mesh seems to be acceptable, but have to be done by expert and competent, at least equal result to Liechtenstein. So it's acceptable, even though it's not the standard is still Liechtenstein for the open mesh. Okay. For open preperitoneal compared to endoscopic, there is not enough evidence, so there is no recommendation. For Liechtenstein compared to laparoscopic, when surgeons have the expertise, both techniques do not take a longer time difference. There's no difference. But the recommendation is that for primary unilateral inguinal repair, laparoscopic, endoscopic is recommended now. This is the very new update right now. The position is if there's expertise, go with the endoscopic because there is less chronic pain. This is the most important issue. Because of the less chronic pain, recommendation is go with endoscopic technique. However, there are patients that warrant Liechtenstein as first choice. In the previous recommendation was that Liechtenstein is the gold standard for the unilateral, but this update no more. They recommend laparoendoscopy. For occult hernia found at time of laparoscopic in unilateral inguinal repair, what is the best treatment? Specifically, when we are doing TAPP, we are doing TAPP and found occult hernia, or doing TEP, and if you explore the other side and you found occult hernia, what do you do? The statement is that concomitant occult hernia repair can increase surgical risk, but it could avoid second reoperation and also avoid the risk of cause and anesthesia. But the risk of progression from occult to symptomatic defect that needs surgery is unknown, probably only 1.2% per year increase, which is quite low. So the statement, the recommendation, which is weak recommendation, is that we should discuss with the patient ahead of time. Every time, if you want to explore the opposite side, that what would you like to do? So inform the patient. Most suitable type for Liechtenstein repair. What mesh type? The recommendation right now is classification of mesh. If it's less than 50 grams per square meters, it's called lightweight. If it's more than 70 grams per square meters, it's called heavyweight mesh. Lightweight mesh reduce post-operative pain in Liechtenstein because it's quite superficial. If you use lightweight, the patient feel less. And for there is no difference between lightweight mesh and heavyweight mesh in Liechtenstein repair. In terms of recurrence are the same. But for the Liechtenstein, the recurrence using partially absorbable, lightweight and partially absorbable, they found that there are more recurrence. So the recommendation, this is a strong recommendation, is that for Liechtenstein repair, try to use lightweight mesh. Open Liechtenstein, use lightweight mesh because of less pain. How about for laparoendoscopic repair? Risk of recurrence is not affected by mesh for laparoscopy for the small hernia and lateral hernia, but the occurrence of chronic pain and also occurrence of chronic pain is not affected by mesh repair. But for heavyweight mesh, it's recommended in large and also medial defect. So for Liechtenstein, we can use lightweight mesh, no difference. But for laparoendoscopic, if you use lightweight on medial defect and or large defect, there are more recurrent. So better to use heavy. So for me, practically is doing Liechtenstein, use lightweight mesh. Using laparoscopy, use heavier one. Except if it's lateral or very small, then you can use lightweight. But the pain have no difference in laparoendoscopy. Prophylactic antibodies. Lots of people were talking about this before. Right now, it appears that worldwide infection risk is very low with low environment. The recommendation is antibiotic is not recommended in elective, open, in average risk patient or in low infection risk. Okay. We think of two factors: patient's factor, high risk or low risk, and environment factor, high risk or low risk. If any of the risk is high in open surgery, go ahead and use antibiotics. If the environmental risk is low, patient risk is low, no need. But for endoscopic, it is not suggested in any risk because they are very, very low. Statistically, it is but it's the recommendation is that antibiotic is not suggested in laparoendoscopic inguinal of any patient or any risk environment. And when we are using antibiotics, recommend cephalosporin or beta-lactamase inhibitors. Anesthesia in open hernia surgery. Local anesthesia is recommended for open repair in any type of patient. Local is as good as general for frail and morbid patient. So local anesthesia is okay. And for regional, like spinal block, epidural block, compared to general anesthesia in patient over 60 and older, have a higher incidence of medical complications. So actually, regional is not good. Okay, general or local is suggested instead of regional in patient above 65. And open inguinal hernia under local is safe even with the trainees under supervision. Chronic post-operative inguinal pain treatment. This trigger point infiltration can be useful. For the diagnosis, MRI can be useful to occlude other pathology. For chronic neuropathic pain, after open repair, both neurectomy and endoscopic neurectomy is acceptable outcome, but it's low evidence. Painful interference with sexual function after open repair can also improve by neurectomy, release of spermatic cord, and mesh removal. This is to consider. Okay. In general, risk around 30% of chronic post-operative inguinal pain surgery will not be effective. So if you do surgery to correct the chronic pain, 30% is not effective. So recommendation is to inform patient for the effectiveness of the correction surgery, that the effectiveness is low, and with the risk of pain intensification and other complications, patient might have more pain. So talk to the patient. Tailor approach is suggested. And also there is so-called microsurgical spermatic cord denervation. This is still in research setting. In clinical practice, nerve block can be useful, but repetitive trigger point infiltration have low evidence of therapeutic value, and no benefit for lidocaine or capsaicin patch for treatment. And radio frequency pulse ablation, RF, may be effective. Neuromodulator of dorsal root ganglion may be effective. The recommendation, strong recommendation, is chronic pain is complex. It's recommended to be treated by specialist center only. Okay, not good for amateur. And pharmacologic intervention we should try for at least 3 months before thinking of doing surgery. What is acute groin hernia? This is some update. There is new definition, not new definition, new wording to use. Acute irreducible hernia is a hernia that cannot be reduced, but previously it was reducible. It's a newly irreducible called acute. But if it's chronically irreducible and with no sudden pain, it's called chronic irreducible. And strangulated hernia means strangulated content. This is to be described only after diagnosis is confirmed by imaging or intraoperative finding. The important one is the term incarcerated hernia should be abandoned. We should no longer use the word incarcerated hernia, but use acute irreducible or chronically irreducible or strangulated, because this one causes a lot of confusion. So stop using the word incarcerated hernia. Okay. Management of potentially bowel ischemia in an acutely symptomatic inguinal hernia is suggested in combination of clinical and biologic and biochemical parameter. Okay, biochemical parameter should not be used alone without clinical examination. Clinical diagnosis is very important and added with biochemical. Acutely irreducible groin hernia is potentially life-threatening and need urgent surgical attention. Successful treatment depends on time of onset and treatment and the bowel viability. So the recommendation is if there is no suspicious of bowel ischemia, we may try manual reduction on the acute irreducible groin hernia. After successful reduction, we can undergo period of observation and until analgesic and sedative drug have worn off, and then we do elective surgery later on. But emergency surgery is recommended immediately if there is suspicious of strangulation. Okay, this is the algorithm for treatment of acute hernia. The patient presented with acute irreducible groin hernia, investigate the sign of strangulation or not, and then biochemical parameter, neutrogen lymphocyte ratio more than 6.5, D-dimer more than 300, and serum phosphokinase more than 140. If there's sign of strangulation, go to emergency surgery right away. If there's no signs of strangulation, you can do manual reduction. If not successful, go to emergency surgery. If successful, then wait for the elective surgery. Best surgical approach for acute groin hernia. Suggest using diagnostic laparoscopy if expertise and resources are available. And laparoscopic repair can be attempted if there is expertise available. And flat mace, we can use it for inguinal hernia. And if we use mesh, the recommendation is use macroporous mesh in acute hernia. Okay. The update did not talk about the biological mesh yet, but macroporous is safe. How about low resource setting? Some country doesn't use commercial mesh. They use like mosquito net and then sterilize it. What are the standing? They said that the evidence is that 1 year follow-up, there is no difference. It's comparable result. But when using non-licensed low-cost mesh, outcome audit at local level are recommended. And it is recommended that the patient be well informed of the type, origin of, surgeon should be well informed of the type of mesh or origin of mesh and safe method to sterilize it. So these are the important update for this time, for the new evidence. For those in training center and in academic settings, I think going through the hernia guidelines is a very good start to see which area that's still lacking in evidence, and you may do research in that area. This is, I always suggest this, that one of the good thing about guideline is go and see which one is the weak point and use it as a starting point to do research and write your paper. Thank you very much.